Daisuke Hasegawa, a Japanese veterinary neurologist. Thank you for inviting me to this lecture series on VetCam. Maybe my English is very poor and difficult to understand, but it will be translated into fluent Spanish, so it may be not a problem, right? Today, I talk about epileptogenesis and epilepsy classification, the basic of epilepsy. The first topic is epileptogenesis. Let's start by reviewing the definition of epilepsy. At first, classical or conceptual definition published by the International League Against Epilepsy, ILAE, was epilepsy is a disorder of the brain characterized by an enduring predisposition to generate epileptic seizure and by the neurobiologic, cognitive, psychological, and social sequences of this condition. The definition of epilepsy requires the occurrence of at least one epileptic seizure. In this classical definition, the yellowed line, an enduring predisposition to generate epileptic seizure, indicates the concept of epileptogenesis. Next, the current clinical definition is, as you know, also used in veterinary medicine, 1. At least 2 unprovoked or reflex seizures occurring over 24 hours apart. In human medicine, there are 2 additional criteria that define epilepsy, but these are not typically used in veterinary medicine. Anyway, the first criterion must occur 2 seizures over 24 hours apart also suggests the meaning of the epileptogenesis. If a patient experiences one seizure or multiple seizures within 24 hours for the first time in their life, that is still not diagnosed as epilepsy. Those seizures are referred to as acute symptomatic seizure (ASS) or reactive seizures. ASS and reactive seizures are synonymous. Now, I guess you can understand somehow what the epileptogenesis is. Okay, here is a descriptive definition of epileptogenesis. Epileptogenesis is the development and extension of tissue capable of generating spontaneous seizures, resulting in development an epileptic condition and or progression of the epilepsy after it is established. So that the term epileptogenesis means the brain becomes epileptic or the brain acquires the ability to generate recurrent seizures, and it is used for epilepsy like established epileptogenesis or acquired epileptogenesis. On the other hand, for developing seizures only, another term, ictogenesis, is used. The term ictogenesis aims to describe the cause of generating seizures and not used for the process of developing epileptic brain. So, ictogenesis is the term that is used before epileptogenesis. Can you understand? Let's see the time course of developing epilepsy. At first, various events such as trauma, vascular disease, status epilepticus, cortical malformation, and gene mutation affect the normal or immature brain as an initial insult, and the brain showed seizures as a response to the insult. At this time, these seizures are referred to as reactive seizure or acute symptomatic seizures, ASS. Those causative events provide ectogenesis to the brain. After that, various microchanges such as neurogenesis, apoptosis, neurodegeneration, gliosis, blood-brain barrier dysfunction, inflammation, synaptic plasticity, channelopathy, and molecular changes are progressed in the brain for a long time, from a few months to a few years. This latency period is the progression of epileptogenesis. During this period, there is no apparent clinical seizure, even though electrical changes such as epileptiform discharges or subclinical seizures are observed on EEG. And then, when a clinically apparent seizure occurs after a certain latency, that means the seizure occurs 2 times over 24 hours apart, so epilepsy is diagnosed, and the brain or patient is referred to as acquired or established epileptogenesis. Epileptogenesis is historically studied and proved by experiments of kindling or cyanuric acid or else. I will explain those later. The bottom boxes indicate therapeutic regimen. The treatment for initial insult and acute therapy for acute symptomatic seizure, such as bolus doses of benzodiazepine, levetiracetam, or anesthesia, and treatment against the causative diseases. And next, actually, we wish we could do this. Prevention of epilepsy is hope-free. Many drugs have been studied to prevent epileptogenesis using kindling or cyanuric acid models. Those are called as anti-epileptogenic medication or anti-epileptogenic drugs. For example, in kindling or cyanuric acid model, used levetiracetam or zonisamide continuously during the latency period. Complete kindling or established epileptogenesis is delayed significantly, so those drugs have the nature of anti-epileptogenesis. Finally, once epilepsy is diagnosed, chronic seizure control will be performed with anti-seizure medication, as we do. To help your understanding, I provide a canine case as an example of epileptogenesis. A male whippet 5 years old. One day, he suddenly showed cluster seizures and non-ambulate left hemiparesis. He was presented to the local clinic and treated with bolus and CRI over midazolam. Cluster seizures ceased and he began to stand. Hemiparesis recovered gradually. 5 days after the event, MRI was performed and revealed a cystic lesion, suspect hematoma in the right front parietal lobe. At this time, he had already recovered to walk so any treatment were not applied. On day 20, a follow-up MRI was performed and confirmed the lesion was hemorrhagic and shrunken. The dog was stable with no seizures and no clinical signs except mild left proprioceptive deficit for a month. However, suddenly a spontaneous seizure occurred on day 45. Again, MRI was performed, but lesion was much more improved. So he was diagnosed with structural epilepsy, referred to as post-stroke epilepsy, and zonisamide therapy was initiated. In this case, the first cluster seizure is acute symptomatic seizures and cannot diagnose as epilepsy at this time. This acute symptomatic seizure is acute physiologic reaction to the cerebral hemorrhage, i.e. reactive seizures. And then, over a 1 month latency period, epileptogenic changes such as free radical production, neuronal death, hemogidrosis, gliosis, blah blah blah, was progressing, and finally, epileptogenesis was established and spontaneous seizures occurred. At this point, epilepsy, in this case structural epilepsy or post-stroke epilepsy, is diagnosed for the first time. Established epileptogenesis means the brain or patient become epileptic. Okay, next, I explain the historically important two models of epilepsy, kindling model and status epilepticus model induced by chymic acid. As you know, in a broad sense, kindling phenomenon is that more seizures occur, the more likely another seizure will occur. This phenomenon originated from the experimental study of kindling model in a narrow sense. Kindling is a method of experiment that a weak and short electrical stimulation provides once a day in a certain area of the brain. For example, as the upper graph of the slide, when a 1 second duration 200 microvolt electrical stimulation is applied to the unilateral amygdala of the cat once a day, the cat shows arrested movement on the first few days, then showed additional facial movement on the next few days, forelimb clonus on the next few days, rear limb on the next few days. In this way, the seizure strength gradually increased, and finally, about 25 to 30 days after starting the stimulation, the cat showed secondary generalized tonic-clonic seizures by same stimulation. This is referred to as kindling completion. If If stimulations are continued after kindling completion, the cat acquires the epileptogenesis. Then, even if stimulation is stopped, the cat begins to show epileptic seizures spontaneously. This kindling experiment proves the existence of the epileptogenesis. In another experiment, cyanic acid, which is one of the glutamate analogues, induces the status epilepticus when it is injected into a certain area of the brain. For instance, only 2 micrograms of cyanic acid is injected into the unilateral amygdala of the cat at once. The cat showed limbic focal status epilepticus, occasionally secondary generalized. This limbic status epilepticus lasts about 3 days. And then, for a few weeks, the cat does not show any clinical sign, but after that, the cat began to show spontaneous focal seizure with or without generalized seizures. The cat is considered to get epileptogenesis during the latent period. This cyanic acid model also proves the epileptogenesis. In both models, an epileptogenic focus was produced in the unilateral amygdala where electrically stimulated or cyanic acid was injected, and the cat became epilepsy. Okay, do you understand the epileptogenesis? Perfect. Interestingly, the day of kindling completion, which is spent days developing into a generalized tonic-clonic seizure, is different between species, and it gets longer as the brain develops more advanced. Therefore, kindling completion day is also considered as phylogenic scale. So kindling completion day of mouse is 6 days and rat and rabbit is 14 days and cat is 25 days and rhesus monkey is 196 days. However, jabirs and dogs, which are thought more intelligent animals than mice or cats, those kindling days are very short, 5 and 7 days respectively. In addition, papio, a kind of baboon which have prone to photosensitivity, also has shorter kindling days than rhesus monkeys. Those species are thought to have a predisposition for epilepsy against the phylogenic scale. In particular, compared between dogs and cats, cat acquired epileptogenesis and developed chronic spontaneous seizure after cyanic acid status epilepticus, while the dog will die during the status, or if survived, the bilateral limbic system, amygdala and hippocampus, develop severe necrosis as shown in the slide. Therefore, the dog is prone to epilepsy and its brain is fragile to seizures compared to the cat. I think this difference between dogs and cats is reflected in the incidence rate of idiopathic epilepsy in each species, which is about 1% for dogs and less than 0.5% for cats. Secondary epileptogenesis is also a well-known phenomenon in both kindling and cyanic acid model and also in clinical practice. Both kindled or cyanic acid treated animals show spontaneous seizure from the primary focus, for example from the unilateral amygdala in the previous mentioned feline cases for the early period. However, as amygdaloid seizure with generalization are repeated, another independent focus is generated. In other words, brain acquires secondary epileptogenesis. In the previous models, if the contralateral amygdala begin to show interictal spikes and spontaneous seizure independently of the original focus, it is called as mirror focus. Or, if the ipsilateral hippocampus shows interictal spikes or spontaneous seizure independent of the amygdala, the hippocampus is referred to as secondary focus or transferred focus. In this way, if seizures are not treated in an epileptic patient, the patient will have multiple foci and many seizures from each focus, resulting in refractory epilepsy. Therefore, early treatment is essentially not for epileptic patients but also the patient with acute symptomatic seizures. Okay? The mechanism of epileptogenesis is very complicated, and I'm not familiar with the molecular or chemical changes, but famous histological changes is very studied, the mossy fibrous protein in the hippocampus. In the normal brain, as you know, one excitatory neuron excites the next excited neuron and simultaneously activate inhibitory neuron to inhibit its own excitement. However, in the chronically epileptic hippocampus, recurrent seizure activity induces the mossy fibrous protein, which is self-excitatory synapse and excites itself recurrently and degenerate inhibitory cells. This reorganization of excitatory circuit is also believed to contribute to establish epileptogenesis and making interactive epilepsy. Okay, the topic of epileptogenesis is over, and next is the epilepsy classification. The International League Against Epilepsy, ILAE, continues to change the epilepsy classification, but the most commonly used classification was in 1989. Up to the 2015 IBETF classification, veterinary medicine also used this 1989 ILAE classification. Then ILAE largely changed the classification in 2010. Idiopathic changed to genetic, symptomatic to structural and metabolic, and probably symptomatic to unknown cause. And IBETF referred to this 2010 ILAE classification and modified it for veterinary use. So, this is the current veterinary classification published by IBETF in 2015. Different from human classification, idiopathic epilepsy has three categories: genetic, probably genetic, and unknown cause. Also different from humans, previous symptomatic epilepsy is changed into structural epilepsy only, and metabolic causes are excluded from epilepsy while included in reactive seizure. Similar to human classification, cryptogenic or probably symptomatic is changed to unknown cause in the original IBTF classification. The patients in this category do not match the criteria of idiopathic epilepsy, but also cannot be identified as structural or metabolic or toxic causes. However, there is the term unknown cause in the subcategory of idiopathic epilepsy, so it's very confusing. Therefore, in the recent textbook by Derigio and Maniana, published in 2022, they renamed these as idiopathic epilepsy of unknown cause and epilepsy of unknown etiology, respectively. As stated above, metabolic causes such as electrolyte abnormalities, hepatic disease, hypoglycemia, renal disease, and toxic causes of seizures are categorized into reactive seizures and excluded epilepsy classification. As well as epilepsy types, seizure types classification has been changed. The most drastic changes were performed in 2010 that were partial seizures changed to focal seizures and stopping to use of simple and complex. Additionally, secondary generalization, which is my favorite term, changed into focal seizure evolving into generalized tonic-clonic seizures. It's very long term. And this is the current veterinary seizure type classification. It's very simple and I like this, except for evolving into generalized seizures. However, on the other hand, human classification has been further changed in 2017 like this. This new classification is mainly classified seizure types at first and subsequently epilepsy types and epilepsy syndromes. In addition, etiology classification is separated as another axis. Adopting the most common canine case with idiopathic epilepsy into this classification, the etiology is unknown, the seizure type is generalized onset, epilepsy type is generalized, so it will be named unknown generalized epilepsy. How do you feel about this classification? And this is the current seizure type classification, which is the basic type. This is a simple version and easy to understand for us, but generalized seizure of this version is too simple. Myoclonic or atonic seizure is omitted. Interestingly, ILAE decided to stop using simple and complex in 2010, but again they renamed as focal aware seizures and focal impaired awareness seizures. and focal seizure evolving into generalized seizure are also further changed into focal to bilateral tonic-clonic seizures. And this is expanded version of the previous one. I think this is better for veterinary use, even though some types are not confirmed in veterinary medicine. Okay, should we fit veterinary classification into human classification? I considered the possibility by reviewing the current status of veterinary epilepsy research. At first, about seizure types. Details of seizure type will be presented in my next lecture, but recent veterinary study about EEG, video EEG, and ambulate video EEG are increasing. These EEG or video EEG studies play a critical role in classifying the seizure type in dogs and cats. For example, the most recent study in the veterinary journal by the team of Dr. Fiona James reveals that non-generalized tonic-clonic seizure, including focal seizure and absence seizure, occupy 1/3 of seizuring dogs, so that as video EEG monitoring spreads more and more, detailed seizure type and epilepsy type classification will be established also in veterinary medicine. Next, about etiology, structural causes have been classified by high-field MRI and pathology based on the MRI findings also in veterinary medicine. On the other hand, unfortunately, genetic and molecular analysis of veterinary epileptic patients has not made much progress. This may be caused by that there is a lack of basic veterinary researcher interested in clinical neurology and epileptology, or because there are few veterinary neurologists who also capable of genetic and molecular analysis. However, even though very slowly, some causative gene and some autoimmune antibodies such as LGI1, VGKC, and NMDA receptor have been revealed in dogs and cats. So, we clinicians should always seek, invite, and encourage molecular biologists as good partners. And if this thing will be progressed, finally, we will be able to establish epilepsy syndrome like as humans. I will talk about epilepsy syndrome at the end of the lecture. Additionally, I'm not familiar, but comorbidities in dogs with epilepsy, such as ADHD-like behavior, anxiety, obsessive-compulsive disorder, and cognitive impairment are hot topics not only in human but also in veterinary medicine. So, maybe we will be able to adopt current ILAE classification to veterinary patients in future, but perhaps by then there will also update ILAE classification. Again, my opinion on future veterinary classification. We have to perform pedigree or genetic analysis and epidemiological analysis in each breed more aggressively, we will find more genetic or probably genetic epilepsies in dogs and cats. And I think a more distinct definition of idiopathic epilepsy of unknown cause and epilepsy of unknown etiology. At present, this difference is only the age of the initial seizure onset. My next opinion is about structural epilepsy. In structural epilepsy from encephalitis, head trauma, and cerebrovascular accident, as I explained in the topic of epileptogenesis, we have to differentiate acute symptomatic seizures and chronic epilepsy. In encephalitis, seizures in the acute phase should be called as acute symptomatic seizures, and only recurrent seizure in the chronic phase, in particular after remission of encephalitis, should be called as post-encephalitis epilepsy. Similarly, immediate seizures or early seizure in trauma and vascular attacks are acute symptomatic seizures, and we should call only late seizures onset over 1 week or 2 weeks after the event as post-trauma or post-stroke epilepsies. Next is degenerative structural epilepsy. Degenerative structural epilepsy includes recurrent seizures from storage disease such as lysosomal storage disease and dementia. In humans, epilepsies related to dementia, including Alzheimer's disease and vascular dementia. Also in our patients, elderly animals develop recurrent seizure. For example, myoclonic seizures are the most common, like Lafora-like disease in dogs and audiogenic reflex seizures in cats. In addition, clinical study reported the relationship between canine cognitive dysfunction and epilepsy has increased. For example, Winter et al. Reported a long duration of epilepsy is related to the early development of canine cognitive dysfunction. Dewey et al. Reported late onset seizure related to microhemorrhages and cognitive dysfunction. And Fonchan-Dacinda et al. Reported amyloid beta levels in dogs with epilepsy is significantly higher than that in healthy dogs. And as splitting high-field MRI in veterinary medicine, many types of cerebral malformation have been revealed. During these 2 decades, holoprosencephaly, lissencephaly, polymicrogyria, heterotopia, schizencephaly, and focal cortical dysplasia are confirmed in dogs and cats more and more. Therefore, not only for epilepsy classification, we veterinary neurologists need categorization of these cerebral malformations like in humans. The slide shows the human classification. Group 1 is irregular neuroproliferation and apoptosis, including hemimegalencephaly and holoprosencephaly. Group 2 is irregular neuronal migration, including lissencephaly and heterotopia. And group 3 is abnormalities after migration, including polymicrogyria and schizencephaly. At last, I think metabolic causes of epilepsy is also included in veterinary classification. As described in the topic of epileptogenesis, for example, recurrent reactive seizures or status epilepticus from hepatic encephalopathy or hypoglycemia would be an initial insult to the brain. If those pathologies are treated, sometimes chronic seizure remains as a sequelae. Those should be metabolic epilepsies, I think. And finally, epilepsy syndromes. Epilepsy syndromes, as also referred as to clinical encephalographic syndromes, is defined as a characteristic clusters of clinical and EEG features, often supported by specific etiological findings such as structural, genetic, metabolic, immune, and infections by ILAE. At present, there is no official epilepsy syndrome in veterinary medicine, but I think some candidate would be syndromes such as feline temporal lobe epilepsy, including hippocampus sclerosis and autoimmune limbic encephalitis, feline audiogenic reflex seizure or epilepsy, elderly onset myoclonic epilepsy in old dogs, and breed-related epilepsy such as Pomeranians focal motor seizure with dystonic limb positionings. Okay, this presentation is finished. In my next lecture, I will talk about diagnostic approach, mainly present the videos of various seizure types. If you have any questions, please mail me via Office of VetCam. Thank you for listening.